So what we're going to go over today is a usable guide for medication. And this guide that we put together is useful in two ways. One is that it can help us to determine if medication effects are present in an EEG that we've recorded. And then two, it can help us to determine, based on the EEG data, what type of medication might be a better fit for the client or the patient. So in the chat, we have pinned two different conversations, or no, maybe one conversation, but linked to two things. There's a list of references, so everybody can see all the research that went into this presentation. If you're curious, it's long. And then the other thing in there is the actual guide to medication, and that is also quite long. One last thing before we get into the presentation. Just so everyone here is aware, there is an updated form, an updated medication guide that's only available through the ISNR. So if you're a member of ISNR or you're thinking about being a member, that's in their members only section. And in their guide, there are links to specific research studies. The one that we've provided here is sort of like the rough draft, and it does not contain the research links. So if you want the research links, you can head over to ISNR and check that out. Okay. Alrighty. So financial disclosures. I work with Dr. Kazem, who's presenting with me here today at a clinic in Nashville. We do not work for any other company, so they're not paying for us to be here today. Like to give thanks to all the people in the field who helped me kind of put this together. A lot of these people have contributed in either compiling data or compiling research, as well as putting together the actual guide. A little bit of background here. I'm just going to talk about myself. Susanna, you can fill in yours. I was a teacher for a long time before I got into neurofeedback. I started working under Rusty Turner in pediatric neurology. I got a master's degree in psychology and later earned my QEEG diploma. And for the past, this needs to be updated, I think I'm at 7 years now. I've been working with Dr. Kazem in Nashville in a pediatric psychiatric clinic.
Hi, everybody. I can't figure out how to change my name, and somehow it's got my husband's username, Google username. I'm not sure how to change that, but I'm Susanna Kazem. Nice to meet you guys. I'm a child psychiatrist and working with Corey in Nashville, Tennessee. So that's a little my background. Did my residency and fellowship at Duke, and then we've been working in Nashville since 2008, and then been doing working with Corey in the EEG and neurofeedback field for the last several years. I've learned a lot from Corey, so I enjoy working with him.
Great, thank you. So what do we expect to learn out of all of this today? What are our goals for today's webinar? I think it's really important anytime we talk about medication that we understand what is within and not within our scope of practice so that we can practice both ethically and legally. So we'll talk about that a little bit. We want to be able to confidently discuss medication choices and why we might recommend those choices. We want to be able to identify EEG phenotypes that respond well to medication and to be able to use the guide that kind of comes with this presentation. So very, very, very important here. We need to talk about scope of practice. If you go to the BCIA website and look up who is allowed to do neurofeedback, you get this sort of laundry list of professions. Psychology, medicine, nursing, physical therapy, occupational therapy, it goes on and on. Speech pathology, sports medicine. And some of the professions here are allowed to prescribe medication and some are not, which means that some people who do neurofeedback can prescribe their own meds or make medication recommendations, and some cannot. And so it's really important to just know, what are you allowed to talk about with your clients? It's absolutely okay to tell a client, that's outside of my scope of practice and I'm not really comfortable talking about it. I have to say that all the time because while I work for a psychiatrist and we see lots of people who are taking medication, I'm not a medical doctor, so I don't recommend medication directly to clients. that would be outside of my scope. So know your scope, know what's in it, know what's not in it, and be comfortable with that. It's a really important piece to talking about medication. Sometimes you have to check with state boards. And this probably, I know in the United States, it varies state by state. It probably varies country by country. So be aware of that as well. This becomes even more important if you're moving outside of neurofeedback and into the world of transcranial stimulation. So alternating current or direct current, photobiomodulation with the iMedi-Sync helmets can do. You know, there's lots of really cool stuff out there. TMS is another one that we've been using recently. But just make sure you know what's inside of your scope and what isn't. If you cannot prescribe medication, you shouldn't make medication recommendations directly to the client. I tell people all the time, I'll talk with your doctor about it. But when you say it directly to the client, oh, I think maybe you would benefit from Lamictal. They tend to hear that as a definitive as opposed to a gentle recommendation. And so you want to avoid putting yourself in hot water and making it sound like you're recommending meds when you're not. So I always try to have that conversation directly with the medication provider as opposed to directly with the client. And then sometimes we do have to talk about medication, whether we're the prescribing provider or we're the neurofeedback provider and we want to talk to the prescriber about medication choices. So like I said before, it's always best to have that conversation with the provider when you're talking with clients or patients about medication. Sometimes things get kind of lost in translation. So best to avoid that, go directly to the provider. If you're an EEG or a neurofeedback specialist, you should be comfortable discussing EEG results and brain phenotypes. That's within your scope, right? If you have a BCN or if you have a QEEG, T or D, this is within your scope of practice, and you should feel really comfortable talking about what a person's EEG looks like. One of the things that I found really helpful when it came to talking about medication and EEG was talking about brains as phenotypes. And even more broadly, just, is this a fast brain or a slow brain? If you tell a medication provider, hey, this kid's brain is really, really slow and we need to speed it up a little bit, that gives them a good direction to go in, even if you're not recommending a specific medication. And the same is true on the opposite end. If this is a really, really fast brain and we want to slow it down some. I highly recommend that you get an ROI and share your EEG reports with everybody on the team, including medication providers. That way everybody's in the loop. And also it gives you a chance to talk to people outside of your practice about EEG and EEG reports and the power that you wield, right? It's a really cool thing to be able to do an EEG for someone, and you want to be able to share that with everybody else on the team. So we try to get an ROI for medication providers, but also therapists, outside counselors, family doctors, pediatricians. We want to make sure everybody on the team gets a copy of the report. If you are going to talk to someone about medication, make sure you stay grounded in literature. Right? You are not recommending, say, Lamictal because you think that's a good fit. You're recommending Lamictal because the literature suggests it's a good fit, right? So you want to stay grounded in research when you do this because, and Susanna and I have kind of come across this many, many times, what the literature recommends for an EEG may not be the best fit for a client, right? And I might look at an EEG and say, this person needs an SSRI. And then Susanna would say, I would never give this person an SSRI because of X, Y, or Z, right? So you want to make sure you stay grounded in the literature and that we're making suggestions or recommendations, certainly not demands. Okay, so I've got a little snippet from our medication guide here on this page. Now, the whole medication guide, which everybody should have access to, it's pinned in the chat, is, I don't know, maybe 15 pages long, and it goes through every medication that has come across our clinic. So what we do is we write out the name of the medication and other names you may find it by, the class of the medication, the reported EEG effects, EEG indications or cautionary factors, the most commonly reported side effects, and the half-life. And this should help you to figure out when you're looking at someone's EEG, if we see, for example, Wellbutrin increases theta, increases SMR, and increases beta, when you look at their EEG, if you see a lot of beta activity, that might be an indication that you're seeing some medication effects there. Just like with Pristique, if you see a decrease in alpha, there's less alpha than you expect, then maybe this is a potential reason why, okay? So we use this originally just to help us interpret the EEG data. That's why we built this guide in the first place. But then as we started going through literature, we came across multiple papers that will recommend specific types of medication for specific EEG phenotypes. And so we added this section on EEG indications. If you see someone has fast, hypercoherent alpha, they may benefit from a tetracyclic or a tricyclic antidepressant. We also, we also added an EEG cautionary factors piece. So for example, with Wellbutrin, there is literature that says if somebody has a fast alpha or a diffuse background beta, they might have adverse reactions to the Wellbutrin. They might run into more common side effects. It might not be as effective as you like. So we added this kind of list of cautionary factors as well. We added the common side effects because for those of you who are familiar with neurofeedback, you probably already know that as you go through the neurofeedback process or neuromodulation, TMS, any type of brain training program, you can sometimes, in some cases, move from a therapeutic dose of medication to having too much medication. And then you may notice an increase in side effects. So in those cases, then it's time to talk to the prescriber and potentially decrease meds. The last thing to note here, in the reported EEG effects, we have written down everything that's noted in the literature. But just like with common side effects, if you give somebody amitriptyline, they're not going to experience all of these side effects, right? They might get one, they might get two, maybe if they're really sensitive, they get more, but very few people are going to have all of them. Well, the EEG effects are the same. If you give someone amitriptyline, they're not going to have increased delta, increased theta, decreased alpha, increased beta. That's just not really the way this works. Most people get one or two of these. Some people get none. Some people get the opposite of these, right? Medication affects every person differently. These are what are most commonly reported in the EEG literature. Okay. Yep. And sorry, this is to summarize that. You might not see all those potential EEG effects. There are some sections in this guide that are left blank, and that means that we don't have enough research to fill those sections yet. The idea for this document is for it to be a living document, one that gets updated on a yearly or bi-yearly basis. And so hopefully, as we continue to learn and as more EEG studies get published, we'll be able to fill in some missing sections. And then the last note here, the EEG phenotypes, they can help guide medication choices. But ultimately, symptoms and medication classes are going to be the deciding factors, right? This guide is not exactly a one-for-one, if this, then this. It's more of a guide in your decision-making tree. But ultimately, you're going to consider the client, you're going to consider their symptoms, and you're going to consider the medication class before making decisions. Okay? So from here, we're going to get into specific classes of medication. And as we go through these classes, we're going to talk about how they affect the EEG and then what EEG factors might cause us to recommend or not recommend them. So we'll start with stimulants and other ADHD medications. Now, generally speaking, stimulants increase beta, although sometimes they will increase alpha as well. They typically decrease slow wave activity. There's a note here that Stimulants are less effective for mu rhythm, which is a specific thing that we'll see in EEG sometimes. And if you've got somebody whose brain is already quite fast, they show a lot of background beta, you want to use caution when recommending stimulants because you can run into adverse side effects. And we have some examples of this to look at. So here we see frontal and center line theta. If you're trained in EEG, you can spot it right here up in the front of the brain, and it's very prominent at FZ right here. This is about a 6 hertz theta rhythm. In your maps, this will show up frontally. Sometimes you'll get it down in the central sensors as well, but predominantly in the front. This is a very classic ADHD marker, although sometimes it's a marker for emotional regulation issues as well. And it tends to respond best to methylphenidate class medication, so stimulant medication. If you look at the phenotype literature, about 35% of ADHD cases fall in this one bucket of excess frontal or central theta. Okay. Now, there's another type of EEG that will show up in your topographical maps in the theta range, but is not actually theta. This is where your EEG can be a little bit tricky to interpret, especially if you're only reading maps. If anybody out here is practicing with EEG, I highly recommend you get comfortable reading raw EEG data as opposed to just mapped data. And in your raw EEG here, what you'll see is that your alpha rhythm is a little bit slow, right? This alpha rhythm peaks at around 7.5 hertz. Well, for an adult, that alpha rhythm should peak around 10 hertz. Now, 7.5 hertz is going to show up in the theta range. That's why we have 6, 7, and 8 hertz all bright red here. But this is a very different type of brain to this one. This is frontal theta. This is slow alpha. And slow alpha is more likely to respond, again, according to the literature, to amphetamine class medication. So that's kind of where we want to think about or where we want to aim if we see somebody who's got a really slow alpha peak. Now, keep in mind, your alpha peak speed or the peak alpha frequency does change by age, right? It's slower in kids. It speeds up to about 9 to 10 hertz by the time you're around 10 years old. And it should stay around 10 hertz until you're about 40 or 50, and then it starts to slow down again. So if you see somebody who's got a peak alpha frequency of 7 hertz, but they're only 6 or 7 years old, I wouldn't necessarily call that a slow alpha. If you see somebody who's 18 and they have a 7 hertz alpha, then I would say that that's slow, right? So keep in mind that there is an age-appropriate piece to this one as well. Now, one of the things that we come across quite a bit in our clinic is mu rhythm. And mu rhythm is identifiable. It's sometimes called owl eyes in the spectral maps. You can see these 2 dots right here in the center. Mu rhythm happens in C3 and C4. We recognize it by the shape of the wave. So it's monomorphic. It means it's curved on the top and pointy at the bottom. This is a very strong mu rhythm that this person has here in C3, C4. And mu rhythm will mimic the symptoms of ADHD in a lot of ways. It can cause trouble with executive function. It can cause trouble with emotional regulation or active listening. Mu rhythm is associated with poor mirror neuron function, so social isolation. Mu rhythm tends to make kids and adults more fidgety, especially with their hands. They tend to get wiggly hands or wiggly fingers. So it looks a lot like ADHD, but the reason behind it is very different. And this is important to know because mu rhythm does not respond well to medication. It does, however, respond to intranasal oxytocin. Now, some people are comfortable recommending that, some people are not. But there are also other ways to boost oxytocin naturally. This is a hormone that our body produces when we're in contact with people we love. So things like hugging people you like, but also just being around people you like, spending time with people you like. Those are all ways that we can boost oxytocin. So if you do an EEG for someone and you see a really strong mu rhythm like this, your brain should start thinking not medication choices, but instead behavioral choices. And that's why I think doing EEG is so important when we're talking about prescribing meds for folks. Now, another common ADHD presentation is called excessive spindling beta. And for those EEG folks out here, you can see it pretty clearly. It's these bursts of very fast activity that happen in frontal, and in this case, even some lateral channels, right? This is excessive spindling beta. Now, this is an ADHD brain. It will get diagnosed as ADHD. It will meet all of the criteria. Sometimes it will also register as anxiety, a little bit scattered or irritable, and defiant. We see a lot of defiant behaviors with beta spindles. Now, usually you see these frontally. Sometimes you see them in central channels as well. If you see beta channels in CZ, it's kind of an insomnia marker. And generally, they're related to poor sleep. So if you see an EEG with beta spindles and you can get that person to improve their sleep, you have a good chance of seeing the beta spindles go down. These represent a kind of irritability of the cortex. Now, even though this brain would be diagnosed as ADHD, this is not a brain you want to give a stimulant to. It's already too fast. It already has too much beta activity. This is a brain that we want to give something a little bit more calming. So guanfacine or gabapentin are the two that we will typically recommend when we see this type of activity or this type of brain. So I've got a case study here, and I'm going to turn it over to Dr. Kazem to talk a little bit about some of the medication choices, but I'll give you the background here. So we had a 10-year-old. He comes in, he's diagnosed with ADHD and ODD. His initial Vanderbilt ADHD scale is quite high, 43 out of 54. His ODD scale is through the roof. It's 24 out of 24. And he came in on both Cotempla and Zoloft. Now, his initial beta activity, which we can see in these beautiful iMedisync maps, is really high. And look, this is 19 hertz all the way up to 27. We saw it in over 3 standard deviations in 7 separate sensors. And then the highest one was at 4.49 standard deviations. So well outside of a normative curve, okay? And then, Susanna, do you want to talk a little bit about kind of why we changed the meds for this kiddo?
Yeah, so, I mean, this kid was having, this is probably a pretty common kind of presentation that we see a lot of in kids. It's a combination of a lot of, some ADHD symptoms and some anxiety types of symptoms. And so, so a lot of times, I'll send them to Corey to and oftentimes they've tried a bunch of different medicines, and so then we're often trying to just kind of gather as much more information as we can get to help guide us with our choices. And so it's really helpful to do a quantitative EEG with Corey, because that helps us to get some more clues about what direction we should go in. So initially, this kid was taking Cotempla, which is an extended release methylphenidate or Ritalin medicine, as well as sertraline, which is Zoloft, which is an SSRI medicine. And so he had a lot of that, fast activity, a lot of spindling beta. And so we kept him on a stimulant, but we changed it to Daytrana, which is the patch version of methylphenidate. So it's a much smoother, longer release, and in general, I've just found that that is much better tolerated for these kids who have significant ADHD, but they also, but they also have faster brains and they're more sensitive brains. And so that's my go-to for these, for these really sensitive kids. And then we also added some guanfacine into the mix. So like Corey said, that one is a kind of a good one. If there's a lot of fast activity, kind of spindling beta activity, then that's, if I can get away with it, then sometimes for ADHD, you'll just start guanfacine all by itself, and kind of see how they do with just that, if they have more of that kind of fast brain type of picture like Corey was talking about. So, and then we kept him on a little bit of his SSRI. So that did seem to be a much better combination for him, and over time he did, he still has some, he still has some challenges. And Corey did some neurofeedback with him too, and that was helpful. But we did, it was better, much better tolerated, and we did kind of get some better scores for his ADHD and ODD, as Corey has listed there.
Yeah, definitely the rating scales improved, and we also saw some changes in brain activity, right? In that initial EEG, we had 7 sensors that were over 3. We had 449 at the highest. In the follow-up EEG, he just had over 2 standard deviations and just 4 sensors. The highest was 2.73. And overall, the high beta decreased from 54 microvolts to 28. So we dropped that beta by about 48%. Now, look, he still has a lot, right? And if you look at these 2 pictures, eyes closed number 1 and eyes closed number 2, it's red and it's red, right? He still has a ton of frontal beta activity. He's reaching 2.73 standard deviations, which is quite high. But we're down from 4.49, right? So it's a really big shift for him. And that registered in a way that his ADHD symptoms improved, his defiant symptoms improved, and his parents were a lot happier at home because he was a lot easier to be around. So that's an example of why we want to do an EEG, why it's helpful to look at someone's brain when we're struggling to kind of figure out the medication choices. This kid, he had all the hallmark symptoms of ADHD, but his brain was actually really fast, and so we wanted to work on slowing some of that down. Next up, we're going to talk about anxiolytics. Now, this is a really broad class of medication. The big thing that we look at with anxiolytics and when to recommend them or not is based on the alpha peak frequency. So that's what you measure in eyes closed. How fast is someone's alpha activity? And we're also going to show an image of what's called benzotoxicity. Benzos have one of the most well-documented medication effects in that they increase beta activity. So we'll get to look at that too. So here we have someone with fast alpha, right? And if we look over here in the spectral, we've got an alpha peak around 10.5 hertz, which is already fast, and a separate alpha peak around 13 or 14 hertz, which is quite fast. This is an example of someone whose baseline processing speed is just too high. They're going too fast kind of all the time. It's a common marker for anxiety, for hyperarousal, rumination, and perfectionism. This is very common in folks who've experienced trauma. And in this case, we want to look for medications that will lower or reduce the peak alpha speed. And one of those is Buspar. That's the one that the literature kind of recommends the most in order to bring down that sort of baseline CPU speed. Now, with regard to benzos, which are used in some clinics as an anxiolytic, we don't really use these a lot here, but I know some people do. When you do a map or even an EEG for somebody who's taking a lot of benzos, the pattern here will be beta spindling. That's what happens with this medication. But you'll see it's a little bit more diffuse compared to the previous beta spindles we looked at. Right here, we get this sort of burst or jolt of beta, and it happens kind of in every sensor. And it might be bigger in some sensors than others, but it happens everywhere. So if somebody comes into your office and their EEG looks like this, it's important to ask them about what medication they might already be taking. So that's kind of on the anxiolytic side. I mean, like I said, the big thing, I'll go back real quick. The big thing is the fast posterior dominant rhythm. That's where we see a lot of anti-anxiety medication play a role. We'll also talk about SSRIs because those can be used as an anti-anxiety medication, but commonly they're used as antidepressants. So typically speaking, SSRIs are a really good fit when we have a lot of excess frontal alpha. When you see really high amplitude alpha in frontal channels, it's a marker for depression or OCD or anxiety, and SSRIs are used in all of those cases. SSRIs tend to work better for people whose alpha is slightly slower, so 9.5 hertz or lower, because they can be a little bit activating. For people who have faster alpha, tricyclic and tetracyclics are kind of the preferred medication choice. So here's an example of some frontal alpha, right? We can see it very clearly in frontal channels up here, FP1, FP2, F3, F4. And I kind of tell clients when we see this, it's like the frontal lobe it's not turned off all the way, but it's stalled a little bit. It's a little bit stuck. And that's why we can sometimes feel a little bit stuck with depression, or a little bit stuck with anxiety, or even stuck with kind of OCD thinking. Now, for you EEG folks, it's important to keep in mind what montage you're using. Sometimes linked ears can cause alpha activity to appear in every sensor. That's called reference contamination. So you have to be careful with that. You got to check across multiple montages to make sure what you're seeing is actually there. That's actually the thing that you're looking for. In your maps here, this one's a little bit slower, right? This alpha peaks at around 8 hertz, some in 7, some in 9. So this is a really good fit for an SSRI. If this alpha were faster, say peaking at 11 hertz, then we would want to think about tricyclics or tetracyclics instead. Then we get into antipsychotics and mood stabilizers. And with these, again, this is a pretty broad class of medication. They typically cause a lot of slowing in the EEG. Usually, they're a good fit for EEGs that show too much high beta or gamma activity. So really, really fast brains, we want to give them the atypical antipsychotics. These are contraindicated by any type of paroxysms, spikes, or discharges. A lot of the atypicals can potentiate seizures. So it's really important that you look at your EEG first before going with that class of medication, because you don't want to increase the risk that somebody might have a seizure. And then that brings us to anti-seizure medication. So sometimes when we do an EEG for someone, we get to see something that we call an isolated epileptiform discharge, right? That's what this is right here. Now, this sort of spike and slow wave can be indicative of a seizure, although only a neurologist can tell you, yes, that's a seizure, or no, it isn't. So when you see this as an EEG person, you just have to be comfortable referring out. This is a referral to neurology. But from a medication perspective, the thing that will help this is anti-seizure medication. Now, some of those anti-seizure medications also carry mood stabilizer labels, right? Like Lamictal is one. I think Depakote's another. And so when we see this type of discharge, it speaks to an inherent instability. And this is a person's brain who's going to need more GABA to help calm down the spike activity. And a lot of the anti-seizure medications are GABAergic. So that's kind of why we want to use that class. Now, an interesting note about this type of activity. This sort of discharge, it happens in about, depending on the study you read, about 6 to 8% of the quote unquote normal population. So people who are not clinically diagnosed. It happens in about 30% of people who have an ADHD diagnosis. So expect to see this a lot more in ADHD diagnosis. And this is when we see this type of activity, even if they're diagnosed with ADHD, the literature suggests not a stimulant, but instead an anti-seizure med. And then, so 30% of ADHD, this is also much more common in panic disorder, where it happens about 20% of the time. And then in autism spectrum, depending on the study, this goes anywhere from 65 to 85% of people on the spectrum. Their brains have a lot of discharges. So in those cases, you are more likely to have successful outcomes if you stay away from the atypical antipsychotics and you lean more into anti-seizure medication. And here's, some of the statistics that I just quoted to you. We see in ADHD, we get around 30%, depending on the study. In mood disorders, it's actually significantly lower, about 3%. And then autism spectrum, Somewhere around 60%, although you do have one study where they did sleep studies. And in the sleep studies, they found almost 86% of kids on the spectrum were having discharges. So quite higher. Okay, so this brings us to case study number 2. We've got a 7-year-old boy. He's diagnosed with autism and he's experiencing aggressive outbursts. We can see initially his ADHD scale, his oppositional defiance scale, and his anxiety scale. And when he came into the office, he was on Risperdal and Lexapro. We had excess delta activity, so very, very slow. And you can see in his EEG, this 1, 2, 3 hertz range, even into the theta, but it's a slow EEG. Excess delta over 2 standard deviations and 8 sensors. The highest was at 3.02. So we did an EEG, and then we decided to make a few changes. And I'll let Susanna kind of talk about that one as well.
Yeah, so this was a kid, it was really, challenging case, a young kid with autism and anxiety and ADHD. Was adopted, so he didn't have many clues from his family history, but he was in lots of behavioral outbursts. So he was initially on, an SSRI and some Risperdal, but he was still, even with the pretty decent dose of the Risperdal, he was still having lots of behavioral outbursts. And I think we tried him on alpha agonist too, like kind of nothing was really helping him that much. So we did an EEG and we did some genetic testing too to try to kind of get some more clues about what might be better fit for this kid. And so on his EEG, he had some of those intermittent epileptiform activity like Corey was kind of talking about. And so we added some Lamictal and started it really small and kind of titrated it pretty slowly. He also was a really slow metabolizer at this cytochrome 2C19, which metabolizes the Lexapro. So we also, Andy's brain was, was pretty slow too. So we kind of backed off on that one because we thought that maybe that was a little too high and kind of agitating him. And that did seem to be, in conjunction with, a lot of ABA therapy and kind of working on things. And that's kind of how this usually goes too, where it's really hard to isolate variables. We're usually doing a bunch of things at once for these challenging kids.
Yeah.
But that did seem to be did help to like move the needle a little bit. And we did, he's still not perfect, but we definitely have kind of improved. His, ADHD scores went down, his ODD's scores dropped, and just the behavioral outbursts and the emotion regulation did get a lot better. And so, so that was a real success story because this was a kid we were trying to think, am I going to we have to go to residential? Or are we going to have, are we going to be able to keep this kid, at home? Because we were having a really tough time and his parents were really, really stressed and strained.
Yeah, he was getting pretty violent at the beginning for sure.
Yeah, police were involved in all the things, even though he was just a little young kid. So as we were kind of, we're improving, then we were able to gradually start kind of slowly weaning the Risperdal. He's still on a tiny bit of the Risperdal, but he's been able to kind of slowly, kind of take that away. And he's also been doing some neurofeedback too. So I think all those things have been helpful for him.
Yeah, absolutely. And just to point out kind of in case you missed it, here in the EEG, this is where we see one of those big spike and wave discharges, right? And so when we see those in the EEG, that's when we want to start thinking about anti-seizure medications. So here we can see, and this one's a little bit more clear in the pre and post maps. Look at how much slow activity we saw in map number 1 compared to what we saw in map number 2. Right? He's still having those discharges, but it is significantly less. We see far less slow activity. Early on, we saw in 8 different sensors, more than 2 standard deviations. And then in the second one, it didn't go over 2 standard deviations in any sensor. The highest was 1.95. The delta magnitude decreased from 670 microvolts in the posterior all the way down to 330. So I think this is a combination, kind of like Susanna said, of yeah, the neurofeedback is helpful, but also the medication is very useful in stabilizing some of that isolated epileptiform content, which is inherently an instability. So when we see that, we want to stay away from the atypicals if we can, and look more into anti-seizure meds. So all in all, and I try to end this a little bit early. I think we've got 10 minutes, so we've got some time for questions. But I try to end this early so that we can have kind of a discussion afterwards. But some big takeaways here. I think EEG amplifiers represent a pretty cheap addition to a medical office, especially compared to an fMRI machine or something like that. And the value that they add is just so high in being able to get a sense of your client's brain, what's going on, and then being able to kind of recommend medication choices with a little bit maybe better accuracy or at least a better starting point. It gives us really valuable insight into what's happening. It reduces the amount of trial and error, which also improves patient outcomes. And with an EEG machine, you get to show pre and post treatment. Even without doing neurofeedback, even if you're just doing medication, you can still do a pre and post EEG to show the effects that the medication has had on the brain. So I think it's a hugely useful tool, and I hope that this medication guide can help people to kind of implement EEG into their practice a little more. We do have a lot of references for this. I shared that in the chat. That's in the pinned document. So yeah, with that said, any questions here?